Scenario 1, digestive system, gastroenterology, gastric ulcer with massive upper gastrointestinal bleeding. A 58-year-old female was rushed to the emergency department following 3 bouts of hematemesis and a single bout of melena. On examination, she was tachycardic and hypertensive at 121 beats per minute and 90/50 millimeters of mercury, respectively. She manifests pallor with no ichorus. She was uropenic and non-dermic. She reports intermittent periumbilical tenderness. Medication history reveals occasional intake of a non-steroid anti-inflammatory drug, naproxen, at 250 milligrams for arthritis management. On admission, her complete blood count revealed a hemoglobin level of 5.1 grams of deciliter, a hematocrit of 32%, prolonged potassium time, and a positive Gaillac test. Other laboratory studies within normal limits. Based on these clinical presentations, intravenous fluids were administered and 3 packs of red blood cells were transfused. A gastroenterologist was consulted and an upper gastrointestinal study was performed, which revealed a 1 times 1 centimeter hemorrhagic gastric ulcer. The bleeding ulcer was cauterized and biopsies were taken for Helicobacter pylori. The results, which are negative. Proton pump inhibitors were started and she was discharged after 2 days in stable condition. Scenario 2, diabetes, subsequent diagnosis of uncontrolled non-insulin dependent diabetes mellitus. A 58-year-old female with non-insulin dependent diabetes mellitus was seen in her primary care provider's office with reports of diminished sensation in both feet and occasional blurred vision. The client admits to problems adhering to a prescribed dietary and medication regimen. She doesn't exercise regularly, takes her medication only when she is reminded, and doesn't watch her diet. She denies dyspnea, polyphasia, polydipsia, polyuria, and diaphoresis. The client has a history of non-insulin dependent diabetes mellitus for 15 years and dyslipidemia, and hypertension. For 8 years, she had laser photocoagulation and retinopathy. In the past year, she is on metformin, glizupate, in control of hyperglycemia, hydrochlorothiazide, and ramipril as antihypertensives, and at atorvastatin and hyperlipidemia. Upon examination, her blood pressure is 185/98 millimeters of mercury. Fasting blood glucose is 265 milligrams per deciliter. Hemoglobin A1C is 9%. Serum blood urea nitrogen and creatine at 53 milligrams per deciliter and 4.4 milligrams per deciliter. Respectively, urinalysis and a 24-hour urine collection uncovered trace proteins and urinary ambient excretion rate of 255 milligrams per day, leading to a diagnosis of microalbuminuria. Nerve conduction studies and electromyography confirmed diabetic neuropathy, decreased visual acuity, and new extensive reticular vascular growth were revealed through an automatic exam. Based on these clients' typical presentation, the vital Medical and present diagnosis is uncontrolled insulin-dependent diabetes mellitus, complicated by hypertension, dyspnea, neuropathy, retinopathy, and microalbuminuria.